What is bladder cancer? Bladder cancer occurs when cells in the bladder start to grow without control. The bladder is a hollow, balloon-shaped organ in the lower part of the abdomen that stores urine. The bladder has a muscular wall that allows it to get larger to store urine made by the kidneys and to shrink to squeeze urine out of the body. There are two kidneys, one on each side of the backbone, above the waist. The bladder and kidneys work together to remove toxins and wastes from your body through urine. Tiny tubules in the kidneys filter and clean the blood. These tubules take out waste products and make urine. The urine passes from each kidney through a long tube called a ureter into the bladder. The bladder holds the urine until it passes through a tube called the urethra and leaves the body. ENLARGE Anatomy of the male urinary system, left panel, and female urinary system, right panel, two-panel drawing showing the right and left kidneys, the ureters, the bladder filled with urine, and the urethra. The inside of the left kidney shows the renal pelvis. An inset shows the renal tubules and urine. Also shown are the prostate and penis, left panel, and the uterus, right panel. Anatomy of the male urinary system, left panel, and female urinary system, right panel, showing the kidneys, ureters, bladder, and urethra. The inside of the left kidney shows the renal pelvis. An inset shows the renal tubules and urine. Also shown are the prostate and penis, left panel, and the uterus, right panel. Urine is made in the renal tubules and collects in the renal pelvis of each kidney. The urine flows from the kidneys through the ureters to the bladder. The urine is stored in the bladder until it leaves the body through the urethra. Types of bladder cancer. Urothelial carcinoma, also called transitional cell carcinoma, is cancer that begins in the urothelial cells, which line the urethra, bladder, ureters, renal pelvis, and some other organs. Almost all bladder cancers are urothelial carcinomas. Urothelial cells are also called transitional cells because they change shape. These cells are able to stretch when the bladder is full of urine and shrink when it is emptied. Other types of bladder cancer are rare. Squamous cell carcinoma is cancer that begins in squamous cells, thin, flat cells lining the inside of the bladder. This type of cancer may form after long-term irritation or infection with a tropical parasite called schistosomiasis, which is common in Africa and the Middle East but rare in the United States. When chronic irritation occurs, transitional cells that line the bladder can gradually change to squamous cells. Adenocarcinoma is cancer that begins in glandular cells that are found in the lining of the bladder. Glandular cells in the bladder make mucus and other substances. Small cell carcinoma of the bladder is cancer that begins in neuroendocrine cells, nerve-like cells that release hormones into the blood in response to a signal from the nervous system. There are other ways to describe bladder cancer. Non-muscle invasive bladder cancer is cancer that has not reached the muscle wall of the bladder. Most bladder cancers are non-muscle invasive. Muscle-invasive bladder cancer is cancer that has spread through the lining of the bladder and into the muscle wall of the bladder or beyond it. Bladder cancer symptoms. The symptoms of bladder cancer can vary from person to person. The most common symptom is blood in the urine, called hematuria. It's often slightly rusty to bright red in color. You may see blood in your urine at one point, then not see it again for a while. Sometimes there are very small amounts of blood in the urine that can only be found by having a test done. Other common symptoms of bladder cancer include frequent urination, pain or burning during urination, feeling as if you need to urinate even if your bladder isn't full, urinating often during the night. When the cancer has grown large or spread beyond the bladder to other parts of the body, symptoms may include being unable to urinate, lower back pain on one side of the body, pain in the abdomen, bone pain or tenderness, unintended weight loss and loss of appetite, swelling in the feet, feeling tired. It's important to check with your doctor if you have any of these symptoms. Keep in mind that urinary tract infections, kidney or bladder stones, or other problems related to the kidney could be the cause, not cancer. Your doctor will ask you when your symptoms started and how often you're having them. They will most likely ask you to give a urine sample as a first step in diagnosing what is causing your symptoms. To learn more, see bladder cancer diagnosis. Bladder cancer screening. Screening is looking for cancer before a person has any symptoms. This can help find cancer at an early stage. When abnormal tissue or cancer is found early, it may be easier to treat. Tests to screen for bladder cancer. There is no standard screening test for bladder cancer in people at average risk. When enough evidence has been collected to show that a screening test is safe, accurate, and useful for people at average risk of bladder cancer, it will become a standard test. However, certain tests may be used to screen for bladder cancer in people who have had bladder cancer in the past or who are at an increased risk of developing it. Hematuria test. Hematuria is red blood cells in the urine. It may be caused by cancer or by other conditions. A hematuria test is used to check for blood in a sample of urine by viewing it under a microscope or using a special test strip. The test may be repeated over time. Urine cytology. Urine cytology is a lab test in which a sample of urine is checked under a microscope for abnormal cells. Urine tumor marker tests. Urinary tumor markers are substances found in the urine that are either made by bladder cancer cells or that the body makes in response to bladder cancer. For this test, a sample of urine is checked in the lab to detect the presence of these substances. Urine tumor marker tests may also be used to help diagnose some types of bladder cancer. Cystoscopy. Cystoscopy is a procedure to look inside the bladder and urethra to check for abnormal areas. A cystoscope, a thin, lighted tube, is inserted through the urethra into the bladder. Tissue samples may be taken for biopsy. ENLARGE cystoscopy. Drawing shows a side view of the lower pelvis containing the bladder, uterus, vagina, rectum, and anus. A cystoscope, a thin, tube-like instrument with a light and a lens for viewing, is shown passing through the urethra and into the bladder. Fluid is used to fill the bladder. An inset shows a woman lying on an examination table with her knees bent and legs apart. She is covered by a drape. The doctor is looking at an image of the inner wall of the bladder on a computer monitor to check for abnormal areas. Cystoscopy. A cystoscope, a thin, tube-like instrument with a light and a lens for viewing, is inserted through the urethra into the bladder. Fluid is used to fill the bladder. The doctor looks at an image of the inner wall of the bladder on a computer monitor to check for abnormal areas. Risks of bladder cancer screening. Screening tests have benefits and risks. Talk with your doctor about whether bladder cancer screening is right for you. Potential risks of harm from bladder cancer screening include false positive and false negative test results. False positive test results. Screening test results may appear to be abnormal even though no cancer is present. A false positive test result, one that shows there is cancer when there isn't, can cause anxiety and is usually followed by more tests, such as cystoscopy or other invasive procedures, which also have risks. False positive results often occur with hematuria testing. Blood in the urine is usually caused by conditions other than cancer. False negative test results. Screening test results may appear to be normal even though bladder cancer is present. A person who receives a false negative test result, one that shows there is no cancer when there is, may delay seeking medical care even if there are symptoms. Bladder cancer diagnosis. If you have symptoms or lab test results that suggest bladder cancer, your doctor will need to find out if they're due to cancer or another condition. Your doctor may ask about your personal and family medical history to learn more about your symptoms and possible risk factors for bladder cancer. Ask for a sample of your urine so it can be checked in the lab for blood, abnormal cells, or infection. Do a physical exam, which for women may include a pelvic exam, to check for signs of cancer. Depending on your symptoms, medical history, and results of your urine lab tests and physical exam, your doctor may recommend more tests to find out if you have bladder cancer, and if so, its extent, stage. Tests to diagnose bladder cancer. The following tests and procedures are used to diagnose bladder cancer. The results will also help you and your doctor plan treatment. Cystoscopy. Cystoscopy is a procedure in which the doctor looks inside the bladder and urethra, the tube that carries urine out of your body, to check for abnormal areas. A cystoscope is slowly inserted through the urethra into the bladder to allow the doctor to see inside. A cystoscope is a thin, tube-like instrument with a light and a lens for viewing. It may also have a tool to remove very small bladder tumors or tissue samples for biopsy. Cystoscopy helps to diagnose, and sometimes treat, bladder cancer and other conditions. ENLARGE cystoscopy. Drawing shows a side view of the lower pelvis containing the bladder, uterus, vagina, rectum, and anus. A cystoscope, a thin, tube-like instrument with a light and a lens for viewing, is shown passing through the urethra and into the bladder. Fluid is used to fill the bladder. An inset shows a woman lying on an examination table with her knees bent and legs apart. She is covered by a drape. The doctor is looking at an image of the inner wall of the bladder on a computer monitor to check for abnormal areas. Cystoscopy. A cystoscope, a thin, tube-like instrument with a light and a lens for viewing, is inserted through the urethra into the bladder. Fluid is used to fill the bladder. The doctor looks at an image of the inner wall of the bladder on a computer monitor to check for abnormal areas. Biopsy. A biopsy is usually done during a cystoscopy procedure. Biopsy is a procedure in which a sample of cells or tissue is removed from the bladder so that a pathologist can view it under a microscope to check for signs of cancer. It may be possible to remove the entire tumor at the time of the biopsy. Talk with your doctor to learn what to expect during and after your cystoscopy and biopsy. Some people have blood in the urine or discomfort and a burning sensation while urinating for a day or two. To learn about the type of information that can be found in a pathologist's report about the cells or tissue removed during a biopsy, see pathology reports. Computed tomography, CT, urogram or intravenous pyelogram, IVP. CT urogram is a test that takes a CT scan of the urinary tract using a contrast dye injected into a vein. To begin the procedure, a CT machine takes a series of detailed pictures of the kidneys. The contrast dye is then injected, and another CT scan of the kidneys, bladder, and ureters is done. About 10 minutes later, a final scan is taken as the contrast dye drains from the kidneys into the bladder. CT urogram also captures detailed pictures of nearby bones, soft tissues, and blood vessels. This allows the doctor to see how well your urinary tract is working and to check for signs of disease. IVP is an X-ray imaging test of your urinary tract. After a contrast dye is injected into a vein, a series of X-ray pictures of the kidneys, ureters, and bladder are taken to find out if cancer is present in these organs. As the contrast dye moves through the kidneys, ureters, and bladder, more X-ray pictures are taken at specific times. This allows your doctor to see how well your urinary tract is working and to check for signs of disease. Urine tumor marker test. Urinary tumor markers are substances found in the urine that are either made by bladder cancer cells or that the body makes in response to bladder cancer. For this test, a sample of urine is checked in the lab to detect the presence of these substances. Urine tumor marker tests may be used to help diagnose some types of bladder cancer. Tests to stage bladder cancer. If you're diagnosed with bladder cancer, you will be referred to a urologic oncologist. This is a doctor who specializes in diagnosing and treating cancers of the male and female urinary tract and the male reproductive organs. They will recommend tests to determine the extent of cancer. Sometimes the cancer is only in the bladder, or it may have spread from the bladder to other parts of the body. The process of learning the extent of cancer in the body is called staging. It is important to know the stage of the bladder cancer to plan treatment. For information about a specific stage of bladder cancer, see bladder cancer stages. The following imaging tests may be used to determine the bladder cancer stage. Computed tomography, CT, scan. A CT scan uses a computer linked to an X-ray machine to make a series of detailed X-ray pictures of areas inside the body from different angles. A dye may be injected into a vein or swallowed to help the organs or tissues show up more clearly. Magnetic resonance imaging, MRI. MRI uses a magnet, radio waves, and a computer to make a series of detailed pictures of areas inside the body, such as the bladder. This procedure is also called nuclear magnetic resonance imaging. Images may be taken at 3 different times after the dye is injected, to get the best picture of abnormal areas in the bladder. This is called triple-phase MRI. Chest X-ray. A chest X-ray is an X-ray of the organs and bones inside the chest. An X-ray is a type of high-energy radiation that can go through the body and onto film, making a picture of areas inside the chest. Bone scan. A bone scan is a procedure that checks to see if there are rapidly dividing cells, such as cancer cells, in the bone. A very small amount of radioactive material is injected into a vein and travels through the bloodstream. The radioactive material collects in the bones with cancer and is detected by a scanner. Getting a second opinion. Some people may want to get a second opinion to confirm their bladder cancer diagnosis and treatment plan. If you choose to seek a second opinion, you will need to get important medical test results and reports from the first doctor to share with the second doctor. The second doctor will review the pathology report, slides, and scans before giving a recommendation. The doctor who gives the second opinion may agree with your first doctor, suggest changes or another approach, or provide more information about your cancer. To learn more about choosing a doctor and getting a second opinion, see Finding Healthcare Services. You can contact NCI's Cancer Information Service via chat, email, or phone, both in English and Spanish, for help finding a doctor, hospital, or getting a second opinion. For questions you might want to ask at your appointments, see Questions to Ask Your Doctor. Bladder cancer prognosis and survival rates. If you've been diagnosed with bladder cancer, you may have questions about how serious the cancer is and your chances of survival. The likely outcome or course of a disease is called prognosis. The prognosis for bladder cancer depends on many factors. The stage of the cancer, including whether the cancer has not reached the muscle wall of the bladder, called non-muscle invasive or superficial bladder cancer, or has spread through the inner lining of the bladder and into the muscle wall of the bladder or beyond it, called muscle-invasive bladder cancer or invasive bladder cancer. The type of bladder cancer. Whether the cancer is low-grade or high-grade. The patient's age and general health. For non-muscle invasive bladder cancer, prognosis also depends on whether there are many tumors or large tumors. The cancer has grown into the connective tissue next to the lining of the bladder. The cancer has come back after treatment. Non-muscle invasive bladder cancer can often be cured. For muscle-invasive bladder cancer, prognosis also depends on whether carcinoma in situ is also present. Survival rates for bladder cancer. Doctors estimate bladder cancer prognosis by using statistics collected over many years from people with bladder cancer. One statistic that is commonly used in making a prognosis is the 5-year relative survival rate. The 5-year relative survival rate tells you what % of people with the same type and stage of bladder cancer are alive 5 years after their cancer was diagnosed, compared with people in the overall population. For example, the 5-year relative survival rate for localized bladder cancer is 71%. This means that people diagnosed with localized bladder cancer are 71% as likely as someone who does not have bladder cancer to be alive 5 years after diagnosis. The 5-year relative survival rates for bladder cancer are as follows. 97% for carcinoma in situ of the bladder alone, abnormal cells found in the tissue lining the inside of the bladder. 71% for localized bladder cancer, cancer is in the bladder only. 39% for regional bladder cancer, cancer has spread beyond the bladder to nearby lymph nodes or organs. 8% for metastatic bladder cancer, cancer has spread beyond the bladder to a distant part of the body. Learn more about statistics for bladder cancer from our Cancer Stat Facts collection. Understanding survival rate statistics. Because survival statistics are based on large groups of people, they cannot be used to predict exactly what will happen to you. The doctor who knows the most about your situation is in the best position to discuss these statistics and talk with you about your prognosis. It is important to note the following when reviewing survival statistics. No two people are entirely alike, and responses to treatment can vary greatly. Survival statistics use information collected from large groups of people who may have received different types of treatment. It takes several years to see the effect of newer and better treatments, so these effects may not be reflected in current survival statistics. To learn more about survival statistics and to see videos of patients and their doctors exploring their feelings about prognosis, see Understanding Cancer Prognosis. Bladder cancer stages. Cancer stage describes the extent of cancer in the body, such as the size of the tumor, whether it has spread, and how far it has spread from where it first formed. It's important to know the stage of bladder cancer to plan treatment. There are several different staging systems for cancer. Bladder cancer is usually staged using the TNM staging system. Your cancer may be described by this staging system in your pathology report. Based on the TNM results, a stage is assigned to your cancer, such as stage I, stage 2, stage 3, or stage 4, may also be written as stage 1, stage 2, stage 3, or stage 4. When talking with you about your cancer, your doctor may describe it as one of these stages. Learn more about cancer staging. Learn about the tests and procedures doctors use to stage bladder cancer. On this page. Stage 0, non-invasive papillary carcinoma and carcinoma in situ. Stage I bladder cancer. Stage 2 bladder cancer. Stage 3 bladder cancer. Stage 4 bladder cancer. Bladder cancer grade. Recurrent bladder cancer. Stage 0, non-invasive papillary carcinoma and carcinoma in situ. ENLARGE Stage 0 bladder cancer, non-invasive bladder cancer. Drawing shows the bladder, lumen, the space where urine collects, ureter, prostate, and urethra. The first inset shows stage 0A, also called non-invasive papillary carcinoma, on the inner lining of the bladder. The second inset shows stage 0A, also called carcinoma in situ, on the inner lining of the bladder. Also shown are the connective tissue and muscle layers of the bladder and the layer of fat around the bladder. Stage 0 bladder cancer, non-invasive bladder cancer. Cancer cells are found in tissue lining the inside of the bladder but have not invaded into the bladder wall. Stage 0A, also called non-invasive papillary carcinoma, may look like long, thin growths extending into the bladder lumen, the space where urine collects. Stage 0 is, also called carcinoma in situ, is a flat tumor on the tissue lining the inside of the bladder. Stage 0 refers to non-invasive bladder cancer. This means that cancer cells are found in tissue lining the inside of the bladder but have not invaded the bladder wall. Stage 0 is divided into stages 0A and 0is, depending on the type of tumor. Stage 0A is also called non-invasive papillary carcinoma, which may look like long, thin growths extending into the bladder lumen, the space where urine collects. Stage 0A can be low-grade or high-grade, depending on how abnormal the cells look under the microscope. See the section on bladder cancer grade. Stage 0 is also called carcinoma in situ, which is a flat tumor on the tissue lining the inside of the bladder. Stage 0 is always high-grade. See the section on bladder cancer grade. Learn about treatment for stage 0 bladder cancer. Stage I bladder cancer. Stage I is a form of non-muscle invasive bladder cancer that has spread into the connective tissue but has not reached the muscle layers of the bladder. ENLARGE stage I bladder cancer, non-muscle invasive bladder cancer. Drawing shows the bladder, ureter, prostate, and urethra. An inset shows cancer in the inner lining of the bladder and in the layer of connective tissue next to it. Also shown are the muscle layers of the bladder and the layer of fat around the bladder. Stage I bladder cancer, non-muscle invasive bladder cancer. Cancer has spread into the connective tissue but has not reached the muscle layers of the bladder. Learn about treatment for stage I bladder cancer. Stage 2 bladder cancer. Stage 2 may also be described as muscle invasive bladder cancer. In stage 2, cancer has spread through the connective tissue into the muscle layers of the bladder. Enlarge. Stage 3 bladder cancer. Stage 3 may also be described as locally advanced bladder cancer. Stage 3 is divided into stages IIIA and IIIB. In stage IIIA, cancer has grown all the way through the bladder muscles and bladder wall into the layer of fat surrounding the bladder and may have spread to the reproductive organs, prostate, seminal vesicles, uterus, or vagina, but has not spread to lymph nodes, or cancer has spread to one lymph node in the pelvis that is not near the major arteries in the pelvis, called the common iliac arteries. ENLARGE2 panel drawing showing stage IIIA bladder cancer in a male, left panel, and a female, right panel. Both panels show cancer in the bladder and in A, the layer of fat around the bladder and B, one lymph node in the pelvis. Also shown are the right and left common iliac arteries, the prostate, left panel, and the uterus, right panel. Stage IIIA bladder cancer. Cancer, A, has grown all the way through the bladder muscles and bladder wall into the layer of fat around the bladder and may have spread to the prostate and or seminal vesicles in men or the uterus and or vagina in women but has not spread to lymph nodes, or, B, has spread to one lymph node in the pelvis that is not near the common iliac arteries. In stage IIIB, cancer has spread to more than one lymph node in the pelvis that is not near the common iliac arteries or to at least one lymph node that is near the common iliac arteries. ENLARGE2 panel drawing showing stage IIIB bladder cancer in a male, left panel, and a female, right panel. Both panels show cancer in the bladder and in A, more than one lymph node in the pelvis that is not near the common iliac artery and B, one lymph node near the common iliac artery. Also shown are the right and left common iliac arteries, the prostate, left panel, and the uterus, the right panel. Stage IIIB bladder cancer. Cancer has spread to A, more than one lymph node in the pelvis that is not near the common iliac arteries, or B, at least one lymph node that is near the common iliac arteries. Learn about treatment for stage 3 bladder cancer. Stage 4 bladder cancer. Stage 4 is divided into stages IVA and IVB. In stage IVA, cancer has spread to the abdominal wall or pelvic wall, or cancer has spread to lymph nodes that are above the major arteries in the pelvis, called the common iliac arteries. In stage IVB, cancer has spread to other parts of the body, such as the lung, bone, or liver. ENLARGE stage IVA and IVB bladder cancer. Drawing shows cancer that has spread from the bladder to A. the abdominal or pelvic wall and B. lymph nodes above the common iliac arteries. Also shown is cancer that has spread to C. other parts of the body, including the lung, liver, and bone. Stage IVA and IVB bladder cancer. In stage IVA, cancer has spread to A. the abdominal or pelvic wall, or B. lymph nodes above the common iliac arteries. In stage IVB, cancer has spread to C. other parts of the body, such as the lung, liver, or bone. Stage 4 bladder cancer is also called metastatic bladder cancer. Metastatic cancer happens when cancer cells travel through the lymphatic system or blood and form tumors in other parts of the body. The metastatic tumor is the same type of cancer as the primary tumor. For example, if bladder cancer spreads to the lung, the cancer cells in the lung are actually bladder cancer cells. The disease is called metastatic bladder cancer, not lung cancer. Learn more in metastatic cancer, when cancer spreads. Learn about treatment for stage 4 bladder cancer. Bladder cancer grade. Cancer grade describes how abnormal the bladder cancer cells look under a microscope and how quickly the cancer cells are likely to grow and spread. Your doctor uses grade and other factors about your cancer, such as its stage, to form a treatment plan and in some cases, to estimate your prognosis. Low-grade bladder cancer cells look more like normal cells and tend to grow and spread more slowly than high-grade cancer cells. High-grade bladder cancer tends to grow and spread more quickly than low-grade bladder cancer. High-grade cancers usually have a worse prognosis than low-grade cancers and may need treatment right away or treatment that is more aggressive. To learn more, see tumor grade. Recurrent bladder cancer. Recurrent bladder cancer is cancer that has recurred, come back, after it has been treated. Bladder cancer tends to recur after treatment, even when it is non-invasive at the time of diagnosis. Low-grade bladder cancer mainly recurs in the bladder lining. High-grade bladder cancer is more likely to have spread to the muscle layers or other parts of the body when it recurs. Tests will be done to help determine where the cancer has returned in your body, if it has spread, and how far. The type of treatment that you have for recurrent bladder cancer will depend on where it has come back. Learn more in recurrent cancer, when cancer comes back. Information to help you cope and talk with your healthcare team can be found in Coping with Bladder Cancer and the booklet When Cancer Returns. Learn about treatment for recurrent bladder cancer. Bladder cancer treatment. Different types of treatment are available for bladder cancer. You and your cancer care team will work together to decide your treatment plan, which may include more than one type of treatment. Many factors will be considered, such as the stage and grade of the cancer, your overall health, and your preferences. Your plan will include information about your cancer, the goals of treatment, your treatment options and the possible side effects, and the expected length of treatment. It will be helpful to talk with your cancer care team before treatment begins about what to expect. Some things you'll want to learn about include what you need to do before treatment begins, how you'll feel while going through it, and what kind of help you will need. To learn more, see questions to ask your doctor about your treatment. For treatment by stage, see Treatment of Bladder Cancer by Stage. On this page. Surgery, radiation therapy, chemotherapy, immunotherapy, targeted therapy, clinical trials, follow-up testing. Surgery. Surgery is the main treatment for bladder cancer. The type of surgery depends on where the cancer is located. Other treatments may be given in addition to surgery. Treatment given before surgery is called preoperative therapy or neoadjuvant therapy. Chemotherapy may be given before surgery to shrink the tumor and reduce the amount of tissue that needs to be removed during surgery. Treatment given after surgery, to lower the risk that the cancer will come back, is called adjuvant therapy. After the doctor removes all the cancer that can be seen, some patients may be given chemotherapy, radiation therapy, immunotherapy, and/or targeted therapy to kill any cancer cells that are left. Learn more about surgery to treat cancer. The types of surgery done to treat bladder cancer are transurethral resection, TUR, with fulguration. During TUR with fulguration, the doctor inserts a cystoscope, a thin lighted tube, into the bladder through the urethra. A tool with a small wire loop on the end is then used to remove the cancer or to burn the tumor away with high-energy electricity. This is known as fulguration. Partial cystectomy. Partial cystectomy is surgery to remove part of the bladder. This may be done for patients who have a low-grade tumor that has invaded the wall of the bladder but is limited to one area of the bladder. Because only a part of the bladder is removed, patients are able to urinate normally after recovering from this surgery. This is also called segmental cystectomy. Radical cystectomy with urinary diversion. Radical cystectomy is surgery to remove the bladder and any lymph nodes and nearby organs that contain cancer. This surgery may be done when the bladder cancer invades the muscle layers or when non-muscle invasive bladder cancer involves a large part of the bladder. In men, the nearby organs that are removed are the prostate and the seminal vesicles. In women, the uterus, the ovaries, and part of the vagina are removed. Sometimes, when the cancer has spread outside the bladder and can't be completely removed, surgery to remove only the bladder may be done to reduce urinary symptoms caused by the cancer. When the bladder must be removed, the surgeon performs a procedure called urinary diversion to create another way for the body to store and pass urine. It may involve redirecting urine into the colon, using catheters to drain the bladder, or making an opening in the abdomen that connects to a bag outside the body for collecting urine. To learn more, see the National Institute of Diabetes and Digestive and Kidney Diseases page on urinary diversion. Radiation therapy. Radiation therapy uses high-energy X-rays or other types of radiation to kill cancer cells or keep them from growing. Bladder cancer is sometimes treated with external beam radiation therapy. This type of radiation therapy uses a machine outside the body to send radiation toward the area of the body with cancer. Radiation therapy may be given alone or with other types of treatment, such as chemotherapy. To learn more, see external beam radiation therapy for cancer and radiation therapy side effects. Chemotherapy. Chemotherapy, also called chemo, uses drugs to stop the growth of cancer cells, either by killing the cells or by stopping them from dividing. Chemotherapy may be given alone or with other types of treatment. The way the chemotherapy is given depends on the type and stage of the cancer being treated. Systemic chemotherapy. Systemic chemotherapy for bladder cancer is when chemotherapy drugs are injected into a vein. When given this way, the drugs enter the bloodstream to reach cancer cells throughout the body. Systemic chemotherapy drugs that may be used to treat bladder cancer are carboplatin, cisplatin, doxorubicin, fluorouracil, 5-FU, gemcitabine, methotrexate, mitomycin, paclitaxel, vinblastine. Combinations of these drugs may be used. Other chemotherapy drugs not listed here may also be used. Intravesical chemotherapy. For bladder cancer, chemotherapy may be intravesical, meaning it is put into the bladder through a tube inserted into the urethra. Intravesical treatments flush the bladder with drugs that kill cancer cells that remain after surgery. This lowers the chance of the cancer coming back. Mitomycin and gemcitabine are two chemotherapy drugs given as intravesical chemotherapy to treat bladder cancer. These drugs can also be given systemically. To learn more about how chemotherapy works, how it is given, common side effects, and more, see chemotherapy to treat cancer and chemotherapy in you, support for people with cancer. Immunotherapy. Immunotherapy helps a person's immune system fight cancer. Your doctor may suggest biomarker tests to help predict your response to certain immunotherapy drugs. Learn more about biomarker testing for cancer treatment. Systemic immunotherapy. Systemic immunotherapy drugs used to treat urothelial cancer, a type of bladder cancer, include avelumab, nivolumab, pembrolizumab. These drugs work in more than one way to kill cancer cells. They are also considered targeted therapy because they target specific changes or substances in cancer cells. See the section on targeted therapy. Intravesical immunotherapy. BCG, Bacillus calmette-guerin, is an intravesical immunotherapy drug used to treat bladder cancer. BCG is given in a solution that is placed directly into the bladder using a catheter, thin tube. Intravesical treatments flush the bladder with drugs that kill cancer cells that remain after surgery. This lowers the chance of the cancer coming back. Targeted therapy. Targeted therapy uses drugs or other substances to block the action of specific enzymes, proteins, or other molecules involved in the growth and spread of cancer cells. Your doctor may suggest biomarker tests to help predict your response to certain targeted therapy drugs. Learn more about biomarker testing for cancer. Targeted therapies used to treat bladder cancer include enfortumab vedotin, erdafitinib, ramucirumab, sacituzumab govitecanzi. To learn more, see targeted therapy to treat cancer. Clinical trials. A treatment clinical trial is a research study meant to help improve current treatments or obtain information on new treatments for patients with cancer. For some patients, taking part in a clinical trial may be an option. Use our clinical trial search to find NCI-supported cancer clinical trials that are accepting patients. You can search for trials based on the type of cancer, the age of the patient, and where the trials are being done. Clinical trials supported by other organizations can be found on the clinicaltrials.gov website. To learn more about clinical trials, see clinical trials information for patients and caregivers. Follow-up testing. Some of the tests that were done to diagnose or stage the cancer may be repeated. Some tests will be repeated to see how well the treatment is working. Decisions about whether to continue, change, or stop treatment may be based on the results of these tests. These tests are sometimes called follow-up tests or checkups. Treatment of bladder cancer by stage. Cancer stage and grade are important factors in deciding the best treatment for bladder cancer. Other factors, such as your preferences and overall health, are also important. For some people, taking part in a clinical trial may be an option. Clinical trials of new cancer drugs or treatment combinations may be available. To learn more about clinical trials, including how to find and join a trial, see clinical trials information for patients and caregivers. Treatment of stage 0 bladder cancer. The main treatment for stage 0 bladder cancer, non-invasive papillary carcinoma and carcinoma in situ, is a surgery called transurethral resection, TUR, with fulguration. Because stage 0 bladder cancer often comes back after surgery, most patients also receive intravesical chemotherapy with mitomycin or gemcitabine at the time of surgery. Some may go on to receive a series of treatments with either intravesical BCG or intravesical chemotherapy. Partial or complete cystectomy, removal of the bladder, is rarely used to treat stage 0 bladder cancer. However, it may be used in people with many tumors or high-grade disease. For more information about these treatments, see bladder cancer treatment. Treatment of stage I bladder cancer. The main treatment for stage I bladder cancer is a surgery called transurethral resection, TUR, with fulguration. Most patients also receive intravesical chemotherapy with mitomycin or gemcitabine at the time of surgery. Some may go on to receive a series of treatments with either intravesical BCG or intravesical chemotherapy. Partial or complete cystectomy, removal of the bladder, is sometimes used to treat stage I bladder cancer that has recurred, came back, after intravesical therapy. For information about these treatments, see bladder cancer treatment. Treatment of stages 2 and 3 bladder cancer. The two main treatments for stage 2 bladder cancer and stage 3 bladder cancer are radical cystectomy or a combination of radiation therapy and chemotherapy. Radical cystectomy is surgery to remove the bladder and surrounding tissues and organs. Surgery to make a new way for urine to leave the body, called urinary diversion, will be done. Additional treatments may be given before or after surgery. Chemotherapy may be given before surgery to patients who are well enough to tolerate it. Giving combination chemotherapy that includes cisplatin before surgery has been shown to help people live longer than surgery alone. The immunotherapy drug nivolumab may be given if the cancer has a high risk of coming back after surgery or did not respond to chemotherapy. Patients who are unable or choose not to have surgery will receive a combination of radiation therapy and chemotherapy, such as cisplatin and fluorouracil, given at the same time. Giving chemotherapy at the same time as radiation therapy helps the radiation therapy work better. Partial cystectomy, removal of part of the bladder, is a less common treatment for stages 2 and 3 bladder cancer. To learn more about these treatments, see bladder cancer treatment. Treatment of stage 4 bladder cancer. Treatment of stage IVA bladder cancer may include systemic chemotherapy, such as one of the following regimens, given alone: methotrexate, vinblastine, doxorubicin, and cisplatin, MVAC. High-dose MVAC. Cisplatin, methotrexate, and vinblastine. A cisplatin-based chemotherapy regimen followed by surgery to remove the bladder and surrounding tissues and organs, radical cystectomy, and urinary diversion or surgery alone. Radiation therapy and chemotherapy, such as cisplatin and fluorouracil, given at the same time, to help the radiation therapy work better. Urinary diversion, as palliative therapy or to prevent a blockage of urine that could cause kidney damage. Surgery to remove part or all of the bladder, cystectomy, as palliative therapy. Treatment of stage IVB bladder cancer may include systemic chemotherapy, such as one of the following regimens: gemcitabine with either cisplatin or carboplatin, methotrexate, vinblastine, doxorubicin, and cisplatin, MVAC. High-dose MVAC. Cisplatin, methotrexate, and vinblastine, CMV. An immunotherapy drug, such as avelumab, nivolumab, or pembrolizumab. Radiation therapy as palliative therapy. Urinary diversion, as palliative therapy or to prevent a blockage of urine that could damage the kidneys. Surgery to remove part or all of the bladder, cystectomy, as palliative therapy. Palliative therapy is treatment meant to relieve symptoms and improve the quality of life of people who have a serious or life-threatening disease, such as cancer. Many of the same treatments for cancer, such as surgery and radiation therapy, can also be used for palliative therapy to help a person feel more comfortable. Learn more about palliative care in cancer. To learn more about these treatments, see bladder cancer treatment. Treatment of recurrent bladder cancer. Treatment of bladder cancer that has recurred, come back, depends on previous treatment and where the cancer has come back. Treatment may include systemic chemotherapy, such one of the following regimens, given alone. Gemcitabine with either cisplatin or carboplatin, methotrexate, vinblastine, doxorubicin, and cisplatin, MVAC. High-dose MVAC. Cisplatin, methotrexate, and vinblastine. An immunotherapy drug, such as avelumab, nivolumab, or pembrolizumab. A targeted therapy drug, such as enfortumab vedotin, or dafitinib, or ramucirumab. Surgery for non-muscle invasive or localized tumors, which may be followed by immunotherapy and chemotherapy. Radiation therapy as palliative therapy. Palliative therapy is treatment meant to relieve symptoms and improve the quality of life of people who have a serious or life-threatening disease, such as cancer. Many of the same treatments for cancer, such as radiation therapy, can also be used for palliative therapy to help a person feel more comfortable. Learn more about palliative care in cancer. To learn more about these treatments, see bladder cancer treatment. Childhood bladder cancer. Childhood bladder cancer is a very rare type of cancer that forms in the tissues of the bladder. The bladder is a hollow, balloon-shaped organ in the lower part of the abdomen that stores urine. The bladder has a muscular wall that allows it to get larger to store urine made by the kidneys, and to shrink to squeeze urine out of the body. There are two kidneys, one on each side of the backbone, above the waist. The bladder and kidneys work together to remove toxins and wastes from the body through urine. Tiny tubules in the kidneys filter and clean the blood. These tubules take out waste products and make urine. The urine passes from each kidney through a long tube called a ureter into the bladder. The bladder holds the urine until it passes through the urethra and leaves the body. ENLARGE Anatomy of the urinary system, drawing showing the right and left kidneys, the ureters, the bladder filled with urine, and the urethra. The inside of the left kidney shows the renal pelvis. An inset shows the renal tubules and urine. The spine and adrenal glands are also shown. Anatomy of the urinary system showing the kidneys, ureters, bladder, and urethra. The inside of the left kidney shows the renal pelvis. An inset shows the renal tubules and urine. Also shown is the spine and adrenal glands. Urine is made in the renal tubules and collects in the renal pelvis of each kidney. The urine flows from the kidneys through the ureters to the bladder. The urine is stored in the bladder until it leaves the body through the urethra. Urothelial carcinoma, also called transitional cell carcinoma, is cancer that begins in the urothelial cells, which line the urethra, bladder, ureters, renal pelvis, and some other organs. The cells of the urothelium are known as transitional cells because they are able to stretch when the bladder is full of urine and shrink when it is emptied. Urothelial carcinoma is the most common form of bladder cancer in children. Squamous cell and other more aggressive types of bladder cancer are less common in children. On this page, risk factors for childhood bladder cancer. Symptoms of childhood bladder cancer. Tests to diagnose childhood bladder cancer. Getting a second opinion. Prognosis of childhood bladder cancer. Types of treatment for childhood bladder cancer. Treatment of newly diagnosed childhood bladder cancer. Treatment of recurrent childhood bladder cancer. Side effects of treatment. Follow-up testing. Coping and support. Risk factors for childhood bladder cancer. Bladder cancer is caused by certain changes to the way bladder cells function, especially how they grow and divide into new cells. To learn more about how cancer develops, see what is cancer? The risk of bladder cancer is increased in children who have been treated for cancer with certain anti-cancer drugs, called alkylating agents, which include cyclophosphamide, ifosfamide, busulfan, and temozolomide. Survivors of heritable retinoblastoma also have an increased risk of developing bladder cancer. Not every child with these risk factors will get bladder cancer, and some children who get the disease don't have any known risk factors. Talk with your child's doctor if you're concerned about your child's risk. Symptoms of childhood bladder cancer. The symptoms of bladder cancer can vary from person to person. The most common symptom of bladder cancer is blood in the urine, called hematuria. It's often slightly rusty to bright red in color. You may see blood in your child's urine at one point, then not see it again for a while. Sometimes there are very small amounts of blood in the urine that can only be found by having a test done. Other common symptoms of bladder cancer can include frequent urination or feeling the need to urinate without being able to do so, pain during urination, abdominal or lower back pain. It's important to check with your child's doctor if your child has any of these symptoms. Keep in mind that urinary tract infections, kidney or bladder stones, or other problems related to the kidney could also be the cause, not cancer. Your child's doctor will ask you when the symptoms started and how often your child has been having them. They'll most likely ask for a urine sample as a first step in diagnosing what is causing these symptoms. Tests to diagnose childhood bladder cancer. If your child has symptoms or lab test results that suggest bladder cancer, their doctor will need to find out if these are due to cancer or another condition. They may ask about your child's personal and family medical history to learn more about your child's symptoms and possible risk factors for bladder cancer. Do a physical exam to feel for signs of cancer. Ask for a sample of urine so it can be checked in the lab for blood, abnormal cells, or infection. Depending on your child's symptoms and medical history and the results of their physical exam and urine lab tests, the doctor may recommend more tests to find out if your child has bladder cancer, and if so, its extent, stage. The results of tests and procedures done to diagnose bladder cancer are used to help make decisions about treatment. The following tests and procedures may be used. CT scan, CAT scan. CT scan is a procedure that makes a series of detailed pictures of areas inside the body, such as the pelvis, taken from different angles. The pictures are made by a computer linked to an X-ray machine. This procedure is also called computed tomography, computerized tomography, or computerized axial tomography. Learn more about computed tomography, CT, scans and cancer. Enlarge. Ultrasound exam. An ultrasound exam is a procedure in which high-energy sound waves, ultrasound, are bounced off internal tissues or organs, such as the pelvis, and make echoes. The echoes form a picture of body tissues called a sonogram. ENLARGE abdominal ultrasound. Drawing shows a child lying on an exam table during an abdominal ultrasound procedure. A technician is shown pressing a transducer, a device that makes sound waves that bounce off tissues inside the body, against the skin of the abdomen. A computer screen shows a sonogram, picture. Abdominal ultrasound. An ultrasound transducer connected to a computer is pressed against the skin of the abdomen. The transducer bounces sound waves off internal organs and tissues to make echoes that form a sonogram, computer picture. Cystoscopy. Cystoscopy is a procedure in which the doctor looks inside the bladder and urethra, the tube that carries urine out of your body, to check for abnormal areas. A cystoscope is slowly inserted through the urethra into the bladder to allow the doctor to see inside. A cystoscope is a thin, tube-like instrument with a light and a lens for viewing. It may also have a tool to remove very small tumors or tissue samples for biopsy. If a cystoscopy is not done at diagnosis, tissue samples are removed and checked for cancer during surgery to remove all or part of the bladder. Getting a second opinion. Some people may want to get a second opinion to confirm their child's bladder cancer diagnosis and treatment plan. If you choose to seek a second opinion, you will need to get important medical test results and reports from the first doctor to share with the second doctor. The second doctor will review the pathology report, slides, and scans before giving a recommendation. The doctor who gives the second opinion may agree with the first doctor, suggest changes or another approach, or provide more information about your child's tumor. To learn more about choosing a doctor and getting a second opinion, see Finding Healthcare Services. You can contact NCI's Cancer Information Service via chat, email, or phone, both in English and Spanish, for help finding a doctor or hospital that can provide a second opinion. For questions you might want to ask at your appointments, see Questions to Ask Your Doctor About Cancer. Prognosis of Childhood Bladder Cancer. If your child has been diagnosed with bladder cancer, you may have questions about how serious the cancer is and your child's chances of survival. The likely outcome or course of a disease is called prognosis. The prognosis can be affected by whether the cancer can be removed by surgery. In children, bladder cancer is usually low grade, not likely to spread, and the prognosis is usually excellent after surgery to remove the tumor. Types of treatment for childhood bladder cancer. There are different types of treatment for children and adolescents with bladder cancer. You and your child's cancer care team will work together to decide treatment. Many factors will be considered, such as your child's overall health and whether the cancer is newly diagnosed or has come back. A pediatric oncologist, a doctor who specializes in treating children with cancer, will oversee treatment. The pediatric oncologist works with other pediatric health professionals who are experts in treating children with cancer and who specialize in certain areas of medicine. This may include the following specialists and others: pediatrician, pediatric surgeon, pediatric urologist, pediatric nurse specialist, rehabilitation specialist, social worker, psychologist, fertility specialist. Your child's treatment plan will include information about the cancer, the goals of treatment, treatment options, and the possible side effects. It will be helpful to talk with your child's cancer care team before treatment begins about what to expect. For help every step of the way, see our downloadable booklet, Children with Cancer, a guide for parents. Surgery. Surgery to remove the cancer and part or all of the bladder is the standard treatment for bladder cancer in children. The type of surgery depends on where the cancer is located and whether it is aggressive. Talk with your child's doctor about how surgery for bladder cancer can affect urinating, sexual function, and fertility. To learn more, see fertility issues in girls and women with cancer and fertility issues in boys and men with cancer. Transurethral resection, TUR. During TUR, the doctor removes tissue from the bladder using a resectoscope inserted into the bladder through the urethra. A resectoscope is a thin, tube-like instrument with a light, a lens for viewing, and a tool to remove tissue and burn away any remaining tumor cells. Tissue samples from the area where the tumor was removed are checked under a microscope for signs of cancer. Cystectomy. Cystectomy, surgery to remove part or all of the bladder, is rarely used to treat bladder cancer in children. However, it may be needed in children with squamous cell carcinoma or more aggressive carcinomas. Clinical trials. A treatment clinical trial is a research study meant to help improve current treatments or obtain information on new treatments for patients with cancer. For some patients, taking part in a clinical trial may be an option. Use our clinical trial search to find NCI-supported cancer clinical trials that are accepting patients. You can search for trials based on the type of cancer, the age of the patient, and where the trials are being done. Clinical trials supported by other organizations can be found on the clinicaltrials.gov website. To learn more about clinical trials, see clinical trials information for patients and caregivers. Because cancer in children is rare, taking part in a clinical trial should be considered. Some clinical trials are open only to patients who have not started treatment. Targeted therapy. Targeted therapy is being studied for the treatment of childhood bladder cancer that has recurred, come back. Targeted therapy uses drugs or other substances to block the action of specific enzymes, proteins, or other molecules involved in the growth and spread of cancer cells. Learn more about targeted therapy to treat cancer. Treatment of newly diagnosed childhood bladder cancer. Treatment of newly diagnosed bladder cancer in children is usually surgery. Transurethral resection, TUR. Surgery to remove the bladder, rare. Learn more about these treatments in the types of treatment section. Treatment of recurrent childhood bladder cancer. Treatment of bladder cancer that has recurred, come back, in children may include a clinical trial that checks a sample of the patient's tumor for certain gene changes. The type of targeted therapy that will be given to the patient depends on the type of gene change. Learn more about clinical trials in the types of treatment section. Side effects of treatment. Learn more about side effects of cancer treatment. Side effects from cancer treatment that begin after treatment and continue for months or years are called late effects. Late effects of cancer treatment may include physical problems, changes in mood, feelings, thinking, learning, or memory. Second cancers, new types of cancer, or other conditions. Some late effects may be treated or controlled. It is important to talk with your child's doctors about the possible late effects caused by some treatments. Learn more about late effects of treatment for childhood cancer. Follow-up testing. Some of the tests that were done to diagnose the cancer may be repeated to see how well the treatment worked. If the bladder cancer recurs, comes back, after treatment, it will usually be within 3 years from diagnosis. Your child will receive tests from time to time after surgery to find out if their condition has changed or if the cancer has recurred. These tests are sometimes called follow-up tests or checkups. Coping and support. When a child has cancer, every member of the family needs support. Honest and calm conversations build trust as you talk with your child and their siblings. Taking care of yourself during this difficult time is also important. Reach out to your child's treatment team and to people in your family and community for support. To learn more, see support for families when a child has cancer. Coping with bladder cancer. When you first learn that you have bladder cancer, you may wonder how you're going to cope with the upcoming changes in your life. One step you can take is to be informed of the physical and emotional changes that may occur and what resources are available to help you. Talking with your healthcare team about your concerns can give you a greater sense of control. Family and friends can also be important sources of support. For resources on the common physical side effects of treatment for bladder cancer, see bladder cancer treatment. For help with emotional side effects, see emotions and cancer. For help after your cancer treatment has ended, see cancer survivorship and our booklet Facing Forward, Life After Cancer Treatment. Adjusting after urostomy. For those who have a stoma and urostomy bag, getting used to them takes time. Some people need to learn how to use a catheter to empty their bladder, which is another big change. And if you have incontinence or problems controlling your bladder, it can be frustrating to deal with. Know that you aren't alone in how you feel. Adjusting to these changes can be hard. But, over time, many people are able to do a lot of what they did before surgery. Support from family members and your healthcare team can help you get used to life after urostomy surgery. Ask your nurse for resources and support groups that may be helpful. Learn more about patients' concerns about surgery. Exit disclaimer. Self-image and sexual problems. Body changes may affect your self-image and sex life after treatment. Some treatments for bladder cancer, including chemotherapy, radiation therapy, surgery, or certain medicines, can cause short-term or long-term problems with sex. For example, having a cystectomy may affect the nerves and make it harder for men to have an erection. Women may have pain during sex or problems with lubrication and orgasm. It's important to discuss any issues and concerns you have about sex with your healthcare team before treatment. Knowing your thoughts ahead of time may help them plan your treatment. Learn more about the sexual problems some cancer treatments can cause and ways to cope in sexual health issues in women with cancer and sexual health issues in men with cancer. For help communicating your feelings, see self-image and sexuality. The stress of follow-up care. It's common for bladder cancer to come back, even after successful treatment. As a result, it is important for people who have been treated for bladder cancer to visit their doctor regularly to get certain follow-up exams or tests. This can be hard for a number of reasons, such as planning and scheduling these appointments can be stressful and time-consuming. Waiting for test results can cause anxiety and an ongoing fear of recurrence. The added costs of things such as co-pays, medicines, and parking and transportation fees only add to the stress. For information about how to prepare for follow-up appointments, see follow-up medical care. For tips on how to deal with the fear of cancer coming back, see the section Coping with Fear of Recurrence on our New Normal page. Cost of cancer treatment. Cancer is one of the most costly diseases to treat in the United States. Even if you have health insurance, you may face major financial challenges and need help dealing with the costs of bladder cancer treatment. Having cancer may also make it hard for you to work and pay your bills. The problems a person has related to the cost of treatment is known as financial toxicity. For ways to cope, see Managing Costs and Medical Information. To learn about financial toxicity and find out if you are at risk, see Financial Toxicity, Financial Distress, and Cancer Treatment. Advances in bladder cancer research. Microscopic section of a papillary urothelial, transitional cell, carcinoma, showing characteristic papillary structures with fibrovascular cores. Microscopic view of a papillary urothelial, transitional cell, carcinoma. Credit, iStock. NCI-funded researchers are working to improve our understanding of how to treat bladder cancer. With recent advances in immunotherapy and targeted therapy, treatment has the potential to become more effective and less toxic. This page highlights some of the latest research in bladder cancer, including clinical advances that may soon translate into improved care and research findings from recent studies. On this page, New bladder cancer treatments. NCI-supported research programs. Bladder cancer research results. New bladder cancer treatments. Bladder cancer treatments are based on the type of bladder cancer and the stage of the disease. The most common type of bladder cancer is transitional cell carcinoma, also called urothelial carcinoma, which begins in cells in the innermost tissue layer of the bladder. There are other types of bladder cancers such as squamous cell carcinoma, small cell carcinoma, and adenocarcinoma, among others. The mainstays of bladder cancer treatment are surgery, radiation therapy, chemotherapy, and immunotherapy, depending on the stage. Scientists continue to study novel treatments and drugs, along with new combinations of existing treatments. Chemotherapy combo effective for common bladder cancer. Gemcitabine and docetaxel combo proves a good alternative to BCG for high-risk non-muscle invasive bladder cancer. Non-muscle invasive bladder cancer is cancer that has grown through the lining of the bladder but hasn't yet invaded the muscle layer of the bladder. Treatment for this cancer is usually to remove the tumor by scraping it from the bladder wall. After surgery, some patients may receive additional treatment with an immune-based therapy called Bacillus calmette-guerin, BCG, or with chemotherapy drugs such as mitomycin C, Jelmyto, or gemcitabine put directly into their bladder to reduce the risk that the cancer will recur. Immunotherapy. Immunotherapy is treatment that helps the body's immune system fight cancer more effectively. In recent years, several different immunotherapy drugs, all of a type called immune checkpoint inhibitors, have been approved for treating certain patients with locally advanced or metastatic bladder cancer. These drugs work by releasing the brakes on the immune system and allowing immune cells to detect and kill tumor cells. Patients whose bladder cancers respond to immune checkpoint inhibitors tend to maintain those responses for long periods. Ongoing clinical trials will help researchers learn whether these extended responses help patients live longer. However, only a small number of patients respond to immune checkpoint inhibitors. Scientists are trying to develop biomarkers that could help doctors identify which patients with bladder cancer are likely to respond to these drugs. The PD-L1 protein, for example, has been studied as a biomarker for response to treatment with immune checkpoint inhibitors. Scientists have now begun to test immune checkpoint inhibitors in earlier stages of bladder cancer and in combination with other treatments, such as chemotherapy. Studies include the below. The NCI-sponsored Ambassador trial is comparing the immune checkpoint inhibitor pembrolizumab, Keytruda, with observation. This is being done in patients with bladder cancer that invades the muscle layer of the bladder wall, localized muscle-invasive disease, or that has spread to nearby lymph nodes, locally advanced disease, and has been surgically removed. The trial will see if pembrolizumab improves overall survival or disease-free survival. In 2021, the Food and Drug Administration, FDA, approved the immune checkpoint inhibitor nivolumab Opdivo as an additional, adjuvant, treatment of patients with urothelial carcinoma who are at high risk of recurrence after undergoing surgery for the disease. This was the first FDA approval for the adjuvant treatment of patients with this type of cancer. In 2023, updated trial results showed that people who received nivolumab had a median disease-free survival of 22 months, compared with about 11 months for those who received a placebo. In 2020, the FDA approved the immune checkpoint inhibitor avelumab, Bavencio, for people with advanced bladder cancer that has shrunk or stopped growing after receiving platinum-based chemotherapy. The approval is for the use of avelumab as maintenance therapy for advanced disease that has not spread, locally advanced, or disease that has spread beyond the bladder, metastatic. Targeted therapy. Targeted therapies use drugs to identify and attack specific types of cancer cells with less harm to normal cells. In 2019, erdafitinib, Balversa, became the first targeted therapy to be approved by FDA to treat patients with locally advanced or metastatic urothelial carcinoma. This drug can be used to treat some patients whose cancers have certain alterations in the FGFR2 gene or FGFR3 gene. Only about 20% of bladder cancers harbor an FGFR gene alteration. An ongoing phase 3 study is comparing erdafitinib with standard chemotherapy and with pembrolizumab in patients with advanced bladder cancer whose tumors have an FGFR gene alteration. This study could help researchers learn whether patients with FGFR-altered bladder cancer benefit more from erdafitinib or an immune checkpoint inhibitor versus chemotherapy. Combination therapy. Researchers are testing many combinations of therapies for bladder cancer, either by combining several immunotherapy drugs or by combining an immunotherapy drug with another type of treatment. An early-phase clinical trial for patients with muscle-invasive bladder cancer is studying the combination of durvalumab, Imfinzi, with tremelimumab before surgery. Giving these drugs together before surgery may make the tumor smaller and reduce the amount of normal tissue that needs to be removed. A phase 3 trial is testing chemotherapy and radiation therapy with or without the immune checkpoint inhibitor atezolizumab in patients with localized muscle-invasive bladder cancer. Combining chemotherapy with radiation therapy may kill more tumor cells than chemotherapy alone. Adding atezolizumab, Tecentriq, to radiation therapy and chemotherapy may further improve outcomes in patients with localized muscle-invasive bladder cancer. A study is testing the safety and efficacy of the combination of the immune checkpoint inhibitor durvalumab and the drug oportuzumab monatox, Vicinium, for treating bladder cancer that has not spread to the muscle in the bladder. Non-muscle invasive bladder cancer is early-stage cancer, but it usually comes back after treatment. The two drugs may act together to help the immune system find and destroy cancer cells. One study is testing the experimental drug enfortumab vedotin alone and with different combinations of treatments, including pembrolizumab, for treating bladder cancer. Some parts of the study will focus on patients with locally advanced and metastatic urothelial cancer, whereas other parts will focus on patients with muscle-invasive bladder cancer. Antibody-drug conjugates. A monoclonal antibody is a type of protein made in the lab that can bind to certain targets in the body, such as those on cancer cells. An antibody-drug conjugate is a substance made up of a monoclonal antibody that is chemically linked to a drug. It has the ability to kill cancer cells without harming other cells. The antibody-drug conjugate enfortumab vedotin Padcev, has also been approved to treat advanced/metastatic bladder cancer. It showed positive results in patients who had previously been treated with chemotherapy and an immune checkpoint inhibitor. Researchers continue to study this drug to see whether it can be used to treat bladder cancer earlier in the disease process and to evaluate it in combination with immunotherapy and/or chemotherapy. Clinical trials for bladder cancer. NCI funds and oversees both early and late-phase clinical trials to develop new treatments and improve patient care. Trials are available for bladder cancer treatment. NCI-supported research programs. Many NCI-funded researchers working at the NIH campus and across the United States and the world are seeking ways to address bladder cancer more effectively. Some research is basic, exploring questions as diverse as the biological underpinnings of cancer. And some is more clinical, seeking to translate this basic information into improving patient outcomes. The Bladder Specialized Program of Research Excellence, or SPORE, is a cornerstone of the NCI's efforts to promote collaborative, interdisciplinary translational research on bladder cancer. It is currently located at Memorial Sloan Kettering Cancer Center. NCI's Division of Cancer Epidemiology and Genetics, DCEG, conducts studies on bladder cancer to learn about risk factors for the disease. Some of their areas of study are described in these bladder cancer research studies. In addition, NCI has funding opportunities for researchers aimed at encouraging investigations of the biology and underlying mechanisms of bladder cancer. Bladder cancer research results. The following are some of our latest news articles on bladder cancer research. Immunotherapy after surgery shows long-term benefits for high-risk bladder cancer. For common form of bladder cancer, chemo combo effective alternative to BCG. Study clarifies timing of immunotherapy for advanced bladder cancer. Enfortumab vedotin approved for recurrent bladder cancer. Targeted drug or dafitinib benefits some patients with advanced bladder cancer. FDA alters approved use of 2 checkpoint inhibitors for bladder cancer. Uterine cancers can be of 2 types, endometrial cancer, common, and uterine sarcoma, rare. Endometrial cancer can often be cured. Uterine sarcoma is often more aggressive and harder to treat. Explore the links on this page to learn more about uterine cancer prevention, screening, treatment, statistics, research, and clinical trials. Advances in endometrial cancer research. Drawing of targeted therapy surrounding the female reproductive system, including the uterus and endometrium. Researchers are testing certain targeted therapies for some types of endometrial cancer. Credit, iStock. NCI-funded researchers are working to advance our understanding of how to prevent, detect, and treat endometrial cancer, which is a type of uterine cancer. The other type, uterine sarcoma, is much less common and can be more aggressive and harder to treat. There are two main subtypes of endometrial cancers, endometrioid and non-endometrioid. Both occur in the inner lining of the uterus, but they look different under a microscope. Endometrioid tumors are more common, they make up 75% to 80% of uterine cancers, are typically diagnosed at an early stage, and may have a favorable prognosis. Non-endometrioid tumors, including serous, clear cell, and other, rarer types of endometrial cancer, are often more aggressive and have a poor prognosis. This page highlights some of the latest research in endometrial cancer, NCI-supported programs that are fueling progress, and research findings from recent studies. On this page, early detection of endometrial cancer. Advances in endometrial cancer treatment. Rising endometrial cancer rates and disparities. NCI-supported research programs. Endometrial cancer research results. Early detection of endometrial cancer. There is no standard screening test for endometrial cancer. Researchers are exploring a variety of ways to detect endometrial cancer before symptoms develop. This includes studying genetic risk factors that increase the risk of endometrial and other cancers. Abnormal bleeding, early-stage endometrial cancer and even atypical hyperplasia of the endometrium, which is not cancer but can become cancer, can cause vaginal bleeding in postmenopausal women. Although bleeding can have many causes, research shows that most postmenopausal women with endometrial cancer had abnormal vaginal bleeding before diagnosis. This confirms the value of follow-up testing in women who have this symptom. New biomarkers. Scientists are looking at potential biomarkers to further improve diagnosis of early endometrial cancer. A biomarker is a molecule found in blood or other tissues that is a sign of a condition or disease. In the DETECT study, for example, researchers from NCI's Division of Cancer Epidemiology and Genetics, DCEG, are studying ways to detect endometrial cancer in samples of uterine tissue collected using tampons. By comparing uterine tissue from women who are having a hysterectomy for endometrial cancer, with tissue from women having a hysterectomy for an unrelated benign condition, scientists hope to find biomarkers that may eventually lead to non-invasive early detection approaches. This study is also designed to reach a racially diverse group of women. Researchers funded by NCI's Early Detection Research Network, EDRN, a network of institutions developing biomarkers to detect cancer in its early stages, designed a test called PAP-seq that analyzes cells from the lining of the uterus. In a research study, the test identified cancer-related DNA alterations in most women with known endometrial cancer, but also in a few women without the disease. More studies of PAP-seq are needed before the test will be ready for use in patient care. Familial genetic risk. Lynch syndrome is an inherited DNA repair disorder in which people have a higher than normal risk of developing certain cancers, including endometrial cancer, colon cancer, and, less frequently, ovarian cancer. About 3% of endometrial cancers are caused by Lynch syndrome. The Society for Gynecological Oncology exit disclaimer recommends that all women diagnosed with endometrial cancer be tested for this disorder. This will aid in treatment decisions and also help with prevention and screening of other cancers in the patient and their blood relatives. Advances in endometrial cancer treatment. Surgery is the standard treatment for early-stage endometrial cancer. Additional treatment, depending on the stage of disease, may include radiation with or without chemotherapy, hormone therapy, immunotherapy, and some targeted therapies. Several new treatments for advanced disease have become available. Molecular subtypes. One area that is changing practice is determining the molecular subtypes of cancers and deciding treatment according to type. Researchers have found that there are different molecular subtypes of endometrial cancer. These subtypes differ in how likely it is that the cancer will come back after treatment. Doctors are now using these subtypes to help choose the best treatments for certain patients with endometrial cancer. For some patients, getting a genetic analysis might be recommended. Going forward, use of molecular analysis of endometrial cancers will be used to guide treatment decisions. This includes intensifying treatment where needed, or reducing the intensity of treatment if it's shown to be safe and equally effective. Immunotherapy. Immunotherapies help the immune system to better fight cancer. One type of immunotherapy, called immune checkpoint inhibitors, has shown promise in treating certain forms of endometrial cancer. In particular, These have helped treat cancers with certain genetic alterations that cause defects in a specific DNA repair process called mismatch repair. Cells with mismatch repair deficiency, dMMR, tend to develop high microsatellite instability, MSIH, in which many mutations arise. Anatomic illustration of stage 3A, 3B, and 3C endometrial cancer. Role of immunotherapy in treating endometrial cancer expands. Adding immune checkpoint inhibitors to standard treatment provides substantial benefits. Endometrial cancers with dMMR/MSIH are found in people with Lynch syndrome-associated endometrial cancers, as well as in up to 35% of endometrial cancers that are not associated with Lynch syndrome. The immune checkpoint inhibitor pembrolizumab, Keytruda, has been approved for treating patients with advanced endometrial cancer that is dMMR or MSIH, cannot be removed surgically, and has gotten worse after other treatments. A different immune checkpoint inhibitor, dostarlimab, is also used for advanced endometrial cancer that is dMMR and is not responding to chemotherapy. Other advances include: an NCI study is testing whether combining the drugs nivolumab and ipilimumab is better than nivolumab alone in shrinking tumors in patients with recurrent endometrial carcinoma that has progressed after earlier treatment with an immune checkpoint inhibitor. The combination of these two drugs has been found to shrink or stabilize other dMMR cancers, but this has not been studied in endometrial cancer until now. Pembrolizumab has also been approved to be used together with the targeted therapy lenvatinib, Lenvima, for some patients with advanced endometrial cancer that is not MSIH or dMMR and has gotten worse after other treatments. A 2022 clinical trial showed that combining the two drugs led to longer progression-free survival and overall survival among patients than using chemotherapy. Initial treatment of people with advanced or recurrent endometrial cancer with the combination of dostarlimab and chemotherapy or the combination of pembrolizumab and chemotherapy improved progression-free survival over chemotherapy alone. The immunotherapy combinations were of particular benefit to people with dMMR tumors. Researchers are also examining the role of adding pembrolizumab to standard radiation therapy for early-stage endometrial cancer that is MSIH or dMMR. Targeted therapy. Targeted therapies are drugs or other substances that interfere with specific molecules or targets to block the growth and spread of cancer with less harm to normal cells. Several targeted therapies are being studied for treating advanced endometrial cancer. Some examples include: one NCI-sponsored trial is studying how well the drugs olaparib, Lynparza, and cediranib maleate, Risentin, work in treating patients with endometrial cancer that has come back, does not respond to treatment, or has spread elsewhere in the body. These drugs may stop the growth of tumor cells by blocking some of the enzymes needed for cell growth. This phase 2 clinical trial is now testing 3 additional combinations of targeted therapies. A new trial will test the combination of olaparib with the chemotherapy drug temozolomide in people with a type of uterine sarcoma called leiomyosarcoma. The hope is that using both drugs together will work better to treat the disease than giving either drug alone. Another trial will test whether adding certain targeted therapies to chemotherapy will shrink tumors in patients with one of 2 rare types of endometrial cancer that have excess amounts of a protein called HER2, also called HER2-positive cancer. The treatment will target the HER2 protein and will be given in a new form, a subcutaneous shot, under the skin, rather than patients having another 4 infusion. The NCI Match trial is one of the first major clinical trials to match people who have cancer with treatment based on genetic changes in their tumor rather than their type of cancer. This trial has shown that targeting genetic changes in a tumor may be an effective way to treat cancer. It has also shown that people with advanced cancer may benefit from genomic sequencing to help plan their treatment. Information learned from NCI Match is leading to new precision medicine trials, such as Combo Match, which will test combinations of drugs. Treatment combinations. Radiation therapy and cisplatin. An NCI randomized phase 2 trial is comparing the combination of radiation therapy and cisplatin with radiation therapy alone in treating patients with endometrial cancer that has come back. The trial is now closed and researchers are analyzing the results. Surgery and chemotherapy versus surgery and chemoradiation. An NCI-funded study found that, among women with locally advanced endometrial cancer, those who received radiation in addition to chemotherapy, chemoradiation, after surgery had the same rate of cancer recurrence as those who received chemotherapy without radiation. More research is needed to determine whether specific groups of patients would benefit from radiation. Rising endometrial cancer rates and disparities. Unlike most other cancers in the United States, endometrial cancer has increased in both incidence and death rates in recent years. These changes reflect increases in aggressive, non-endometrioid subtypes of uterine cancer, with endometrioid subtypes having remained fairly stable. Recent studies have shown that these increases are seen in all racial and ethnic groups. However, a 2019 study from NCI showed that Black women have the highest incidence rates, and a 2022 NCI study showed that they have higher death rates and the poorest survival. The reasons for the increases in non-endometrioid subtypes and the disparities across groups are not clear, but NCI-funded studies are seeking to understand their origin. For example, in addition to studying biomarkers in tampon specimens, the aforementioned DETECT study has expanded their aims to investigate possible sources of these disparities, such as differences in risk factors, in molecular markers, and in care delays. The Carolina Endometrial Cancer Study Exit Disclaimer seeks to address this gap in a clinical trial that analyzes endometrial tumors to identify genetic details and guide treatment strategies. Women from across the state of North Carolina will be recruited, with a goal of half the participants being Black. NCI-supported research programs. Many NCI-funded researchers at the NIH campus, and across the United States and the world, are seeking ways to address uterine cancer more effectively. Some research is basic, exploring questions as diverse as the biological underpinnings of cancer and the social factors that affect cancer risk. And some is more clinical, seeking to translate this basic information into improving patient outcomes. The Endometrial Specialized Programs of Research Excellence, SPORES, promotes collaborative translational cancer research. This group works to improve prevention and treatment approaches, along with molecular diagnostics, in the clinical setting to help patients with endometrial cancer. NCI's Division of Cancer Prevention, DCP, is addressing rising endometrial cancer rates by supporting gynecologic cancer prevention research and developing concepts for future studies. Approaches to identify and care for individuals with inherited cancer syndromes seeks the best approaches to identify those with an inherited cancer syndrome and provide appropriate follow-up care. The NCI-funded Colon Cancer Family Registry Exit Disclaimer has established an international cohort of thousands of colorectal cancer patients, their relatives, and other individuals at increased risk of colorectal and other cancers, including endometrial cancer. More than 10,000 families from the United States, Canada, Australia, and New Zealand have been registered. The database includes more than 2,000 individuals with Lynch syndrome from 781 families. The Epidemiology of Endometrial Cancer Consortium, E2C2, is an NCI-supported consortium studying the causes and origins of this cancer through collaboration among investigators. The goal of E2C2 is to combine data across studies to better understand endometrial cancer. Clinical trials for uterine cancer. NCI funds and oversees both early and late-phase clinical trials to develop new treatments and improve patient care. Trials are available for the treatment of both endometrial cancer and uterine sarcoma. Endometrial cancer research results. The following are some of our latest news articles on endometrial cancer research. Immunotherapy's role in treating endometrial cancer expected to grow. Trastuzumab may improve survival in women with rare endometrial cancer. Women experience more side effects from pelvic radiation than realized. Can some women treated for endometrial cancer forego radiation after surgery? Study shows incidence rates of aggressive subtypes of uterine cancer rising. Study provides closer look at postmenopausal bleeding and endometrial cancer. Pancreatic cancer can develop from two kinds of cells in the pancreas, exocrine cells and neuroendocrine cells, such as islet cells. The exocrine type is more common and is usually found at an advanced stage. Pancreatic neuroendocrine tumors, islet cell tumors, are less common but have a better prognosis. Explore the links on this page to learn more about pancreatic cancer treatment, statistics, research, and clinical trials. Advances in pancreatic cancer research. Pancreatic cancer cells growing in a sphere-shaped cluster. Pancreatic cancer cells, blue, growing as a sphere encased in membranes, red. Credit, National Cancer Institute. NCI-funded researchers are working to advance our understanding of how to prevent, detect, and treat pancreatic cancer, which includes pancreatic ductal adenocarcinoma, PDAC, and pancreatic neuroendocrine tumors, PNET. PNET is much less common than PDAC and has a better prognosis. This page highlights some of the latest research in pancreatic adenocarcinoma, including clinical advances that may soon translate into improved care, NCI-supported programs that are fueling progress, and research findings from recent studies. On this page, early detection of pancreatic cancer, pancreatic cancer treatment, clinical trials, NCI-supported research programs, pancreatic cancer research results, early detection of pancreatic cancer. Currently, no screening tests exist that can catch pancreatic cancer early, before symptoms develop. NCI is now funding several large research projects that are working to develop such an early detection tool. One known risk factor for developing pancreatic cancer is a new diagnosis of diabetes, sometimes called new-onset diabetes. About 1 in 100 people with new-onset diabetes are diagnosed with pancreatic cancer within 3 years after learning they have diabetes. And 1 in 4 people who get pancreatic cancer had already been diagnosed with diabetes. The NCI-funded New-Onset Diabetes (NOD) study, which is scheduled to run through 2025, is currently enrolling 10,000 people with new-onset diabetes or hyperglycemia, also known as prediabetes. The NOD researchers hope to develop a blood test that can identify the few individuals with a new diabetes diagnosis who may need further testing for pancreatic cancer. Other NCI-funded teams, coordinated through the Pancreatic Cancer Detection Consortium, PCDC, are trying to create a blood test that could pick up early pancreatic cancer in the general population. PCDC researchers are also working to improve imaging of the pancreas by developing methods that may be able to pick up tiny deposits of tumor cells. Pancreatic cancer treatment. Pancreatic cancer can be hard to treat surgically due to the location of the organ, and because the disease has often spread in the body by the time it is diagnosed. Pancreatic cancer research highlights. Hear about promising developments in pancreatic cancer research in this excerpt from a Facebook Live event with Dr. Christine Allewine of NCI's Center for Cancer Research and Dr. Lynn Matrisian of the Pancreatic Cancer Action Network. Standard treatment for pancreatic cancer usually consists of surgery, chemotherapy, radiation, or combinations of each, depending on the cancer's stage. Beyond these standard treatments, NCI scientists continue to look for ways to treat pancreatic cancer more effectively. Researchers are looking at the potential of new drugs, ways to combine standard drugs, and new therapies to give to patients. Testing treatments for early-stage pancreatic cancer. Therapies for early-stage disease that are being tested in clinical trials right now are new adjuvant chemotherapy drug combinations. Some of these post-surgical drug combinations are already known to extend the lives of patients with metastatic disease, but it's not clear if they are better at killing cancer cells left behind after surgery than standard treatments. Neoadjuvant chemotherapy. This form of chemotherapy is given before surgery, with the goal of improving outcomes by shrinking the tumor before it's removed. Pre-surgical chemotherapy also may help by killing cancer cells that have escaped from the tumor that would continue to grow as the patient recovers from surgery. Testing treatments for advanced pancreatic cancer. New treatments for metastatic pancreatic cancer that are being investigated in clinical trials are: drug targets common mutation in pancreatic cancer. In mice, experimental drug MRTX1133 shrank pancreatic tumors with KRAS G12D mutations. RAS-directed therapies. The RAS genes make proteins that take part in signaling pathways that control cell growth. Altered forms of these genes are found in more than 90% of pancreatic cancers. Developing drugs that target mutant forms of RAS has proved challenging. Such drugs are now becoming available, such as a drug that targets a form of RAS that has a mutation called G12C and another drug that targets a more common mutation, G12D. Researchers have found that drugs blocking the activity of proteins that mediate the effects of RAS force cancer cells to rely on a way of creating energy called autophagy. A study in mice found that a combination of 2 drugs shrank pancreatic tumors. One drug targets a protein that RAS works through, and the other drug blocks autophagy. Whether such combinations will be effective in pancreatic patients is still being studied. Immunotherapy. Pembrolizumab. A rare group of people with pancreatic cancer have mutations in their tumor that cause high microsatellite instability, MSI. Pembrolizumab, Keytruda, is an immune checkpoint inhibitor approved for patients with pancreatic cancer that has high MSI. Immune checkpoint inhibitors work by helping the patient's own immune system fight their tumor. Patients should ask to have their tumors tested for high MSI. Immune checkpoint inhibitor combinations. Using one drug for immunotherapy treatment has not been effective for most people with pancreatic cancer. Therefore, researchers are combining several immunotherapies that can act on different parts of the immune system. For example, combining immune checkpoint inhibitors with a type of drug called CD40 agonist, which helps activate T cells, has shown some evidence of benefit in patients with advanced pancreatic cancer. Combinations of drugs and treatments. Scientists are now studying combinations of immunotherapy drugs. They are also studying combinations of immunotherapy drugs with other treatments, such as radiation therapy, stromal modifying agents, and other targeted drugs. Natural killer cells. Natural killer cells, NK, cells are a type of white blood cell that can kill tumor cells or cells infected with a virus. NK cell therapies for pancreatic cancer are being tested in early-stage clinical trials. Stroma-modifying drugs. The stroma is the dense tissue around a tumor that does not contain cancer cells. It is mostly made up of connective tissue, blood vessels, lymphatic vessels, and nerves. Pancreatic cancers have much denser stroma than most tumors. Agents that help break down this stroma may help more chemotherapy drugs reach cancer cells. These drugs are being tested now. Clinical trials. Because of the complex nature of pancreatic cancer, many experts believe it's important for all patients to join a clinical trial, even if they have early-stage disease. NCI funds and oversees both early and late-phase clinical trials to develop new treatments and improve patient care. Trials are available for pancreatic cancer treatment. NCI-supported research programs. Many NCI-funded researchers at the NIH campus, and across the United States and world, are seeking ways to address pancreatic cancer more effectively. Some research is basic, exploring questions as diverse as the biological underpinnings of cancer and the social factors that affect cancer risk. And some is more clinical, seeking to translate this basic information into improved patient outcomes. The programs listed below are a small sampling of NCI's research efforts in pancreatic cancer. The Pancreatic Cancer Cohort Consortium consists of more than a dozen prospective epidemiologic cohort studies that investigate the causes and natural history of pancreatic cancer. This includes the launching of a genome-wide association study, GWAS, known as PanScan. The Pancreatic Cancer Detection Consortium, PCDC, develops and tests biomarkers to detect early-stage pancreatic cancer and identify individuals at high risk for the disease. The Pancreatic Cancer Microenvironment Network, PACMEN, exit disclaimer, is an NCI-funded consortium created to conduct both laboratory-based and clinical studies to improve therapeutic outcomes for patients with pancreatic cancer. The Pancreatic Ductal Adenocarcinoma, PDAC, Stromal Reprogramming Consortium, PSRC, is a multidisciplinary community of PDAC researchers that will bridge biological research with preclinical/translational research. The goal is to identify and evaluate elements in the tumor microenvironment that drive PDAC progression and response to therapy. The Pancreatic Specialized Programs of Research Excellence, pancreatic spores, are designed to quickly move basic scientific findings into clinical settings. The pancreatic spore grants support new and diverse approaches to the prevention, early detection, diagnosis, and treatment of pancreatic cancer. Two of NCI's gastrointestinal, GI, spores also conduct research in pancreatic cancer. The RAS initiative looks to understand mutations in RAS genes to ultimately create effective, new therapies for RAS-related cancers. More than 90% of pancreatic cancers are caused by mutations in the RAS family of genes. Prostate cancer is the most common cancer and the second leading cause of cancer death among men in the United States. Prostate cancer usually grows very slowly, and finding and treating it before symptoms occur may not improve men's health or help them live longer. Explore the links on this page to learn about prostate cancer treatment, prevention, screening, statistics, research, and more. Advances in prostate cancer research. Prostate cancer cells interacting with polymeric nanoparticles coated with targeting molecules. Nanoparticles are tested as a means to deliver drugs to prostate cancer cells. Credit, National Cancer Institute. NCI-funded researchers are working to advance our understanding of how to prevent, detect, and treat prostate cancer. Most men diagnosed with prostate cancer will live a long time, but challenges remain in choosing the best treatments for individuals at all stages of the disease. This page highlights some of the latest research in prostate cancer, including clinical advances that may soon translate into improved care, NCI-supported programs that are fueling progress, and research findings from recent studies. On this page, studying early detection for men at high risk. Diagnosing prostate cancer. New prostate cancer treatments. NCI-supported research programs. Prostate cancer research results. Studying early detection for men at high risk. Men with certain inherited genetic traits are at increased risk for developing prostate cancer. Examples of such traits include inherited BRCA gene mutations and Lynch syndrome. No clear guidelines exist for when or how or if to screen men at high genetic risk for prostate cancer. NCI researchers are using magnetic resonance imaging, MRI, of the prostate in men at high risk to learn more about how often and how early these cancers occur. They're also testing whether regular scans in such men can detect cancers early, before they spread elsewhere in the body, metastasize. Diagnosing prostate cancer. Improving biopsies for prostate cancer. Traditionally, prostate cancer has been diagnosed using needles inserted into the prostate gland in several places under the guidance of transrectal ultrasound, TRUS, imaging to collect samples of tissue. This approach is called systematic biopsy. However, ultrasound does not generally show the location of cancer within the prostate. It is mainly used to make sure the biopsy needles go into the gland safely. Therefore, biopsy samples using ultrasound guidance can miss cancer altogether. Or they may identify low-grade cancer while missing areas of high-grade, potentially more aggressive cancer. Some doctors, concerned that a systematic biopsy showing only low-grade cancer could have missed a high-grade cancer, may suggest surgery or radiation. However, in some cases these treatments will be for a cancer that may have never caused a problem, which is considered overtreatment. Using MRI and ultrasound. Scientists at NCI have developed a procedure that combines magnetic resonance imaging, MRI, with TRUS for more accurate prostate biopsies. MRI can locate potential areas of cancer within the gland but is not practical for real-time imaging to guide a prostate biopsy. The procedure, known as MRI-targeted biopsy, uses computers to fuse an MRI image with an ultrasound image. This lets doctors use ultrasound guidance to take biopsy samples of areas of possible cancer seen on MRI. NCI researchers have found that combining MRI-targeted biopsy with systematic biopsy can increase the detection of high-grade prostate cancers while decreasing detection of low-grade cancers that are unlikely to progress. Testing machine learning. Researchers are testing the use of machine learning, also called artificial intelligence, AI, to better recognize suspicious areas in a prostate MRI that should be biopsied. AI is also being developed to help pathologists who aren't prostate cancer experts accurately assess prostate cancer grade. Cancer grade is the most important factor in determining the need for treatment versus active surveillance. Finding small amounts of prostate cancer using imaging and PSMA. NCI-supported researchers are developing new imaging techniques to improve the diagnosis of recurrent prostate cancer. A protein called prostate-specific membrane antigen, PSMA, is found in large amounts and almost exclusively on prostate cells. By fusing a molecule that binds to PSMA to a compound used in PET imaging, scientists have been able to see tiny deposits of prostate cancer that are too small to be detected by regular imaging. The Food and Drug Administration, FDA, has approved 2 such compounds for use in PET imaging of men with prostate cancer. These approvals are for men whose cancer may have spread to other parts of the body but is still considered curable either with surgery or other treatments. The ability to detect very small amounts of metastatic prostate cancer could help doctors and patients make better informed treatment decisions. For example, if metastatic cancer is found when a man is first diagnosed, he may choose an alternative to surgery because the cancer has already spread. Or doctors may be able to treat cancer recurrence either in the prostate or metastatic disease earlier, which may lead to better survival. Studies are being done to determine if such early detection can improve outcomes. As part of the Cancer Moonshot, NCI researchers are testing whether PSMA PET imaging can also identify men who are at high risk of their cancer recurring. Such imaging may eventually be able to help predict who needs more aggressive treatment such as radiation therapy in addition to surgery after diagnosis. Research teams are also looking at whether certain patterns seen on PSMA tests taken over time may indicate an increased risk of recurrence after initial treatment. How small metastases discovered with PSMA change over time, with or without treatment. New prostate cancer treatments. Standard treatments for prostate cancer that has not spread elsewhere in the body are surgery or radiation therapy, RT, with or without hormone therapy. Active surveillance is also an option for men who have a low risk of their cancer spreading. This means monitoring the cancer with regular biopsies and holding off on treatment unless there is evidence of progression. Rates of active surveillance more than doubled between 2014 and 2021, to almost 60% of U.S. men diagnosed with low-risk prostate cancer. Hormone therapy for prostate cancer. Over the last decade, several new approaches to hormone therapy for advanced or metastatic prostate cancer have been approved for clinical use. Many prostate cancers that originally respond to treatment with standard hormone therapy become resistant over time, resulting in castrate-resistant prostate cancer, CRPC. For newer drugs have been shown to extend survival in some groups of men with CRPC. All inhibit the action of hormones that drive CRPC. Enzalutamide, Standi. Abiraterone, Zytiga. Darolutamide, Nubeqa. Apalutamide, Erleada. These drugs are now also used in some people whose prostate cancer still responds to standard hormone therapies but has spread elsewhere in the body, metastasized. Scientists are continuing to study novel treatments and drugs, along with new combinations of existing treatments, in men with metastatic and castration-resistant prostate cancer. PARP inhibitors for prostate cancer. A PARP inhibitor is a substance that blocks an enzyme in cells called PARP. PARP helps repair DNA when it becomes damaged. Some prostate tumors have genetic defects that limit their ability to repair DNA damage. Such tumors may be sensitive to PARP inhibitors. Two PARP inhibitors, olaparib, Lynparza, and rucaparib, Rubraca, have been approved for some men whose prostate cancer has such genetic defects and has metastasized, and whose disease has stopped responding to standard hormone treatments. Ongoing studies are looking at combing PARP inhibitors with hormone therapies. Immunotherapy, vaccines for prostate cancer. Immunotherapies are treatments that harness the power of the immune system to fight cancer. These treatments can either help the immune system attack the cancer directly or stimulate the immune system in a more general way. Vaccines and checkpoint inhibitors are two types of immunotherapy being tested in prostate cancer. Treatment vaccines are injections that stimulate the immune system to recognize and attack a tumor. One type of treatment vaccine called Sipuleucel-T, Provenge, is approved for men with few or no symptoms from metastatic CRPC. Immunotherapy, checkpoint inhibitors for prostate cancer. An immune checkpoint inhibitor is a type of drug that blocks proteins on immune cells, making the immune system more effective at killing cancer cells. Two checkpoint inhibitors, pembrolizumab, Keytruda, and dostarlimab, Jemperli, have been approved for the treatment of tumors, including prostate cancers, that have specific genetic features. Pembrolizumab has also been approved for any tumor that has metastasized and has a high number of genetic mutations. But relatively few prostate cancers have these features, and prostate cancer in general has largely been resistant to treatment with checkpoint inhibitors and other immunotherapies, such as CAR T-cell therapy. Research is ongoing to find ways to help the immune system recognize prostate tumors and help immune cells penetrate prostate tumor tissue. Studies are looking at whether combinations of immunotherapy drugs, or immunotherapy drugs given with other types of treatment, may be more effective in treating prostate cancer than single immunotherapies alone. Targeted radiation therapy and PSMA. Scientists have developed targeted therapies based on PSMA, the same protein that is being tested for imaging prostate cancer. For treatment, the molecule that targets PSMA is chemically linked to a radioactive compound. This new compound can potentially find, bind to, and kill prostate cancer cells throughout the body. In a recent clinical trial, men with a type of advanced prostate cancer who received a PSMA-targeting drug lived longer than those who received standard therapies. This trial led to FDA approval of the drug, Lu-177 PSMA-617, Pluvicto, to treat some people with metastatic prostate cancer. Ongoing and planned clinical trials are testing PSMA-targeting drugs in patients with earlier stages of prostate cancer, and in combination with other treatments, including targeted therapies like PARP inhibitors and immunotherapy. Personalized clinical trials for prostate cancer. Research is uncovering more information about the genetic changes that happen as prostate cancers develop and progress. Although early-stage prostate cancer has relatively few genetic changes compared with other types of cancer, researchers have learned that metastatic prostate cancers usually accumulate more mutations as they spread through the body. These mutations may make men with metastatic prostate cancers candidates for what are called basket clinical trials of new drugs. Such trials enroll participants based on the mutations found in their cancer, not where in the body the cancer arose. In the NCI MATCH trial, a high percentage of enrolled men with advanced prostate cancer had mutations that could potentially be targeted with investigational drugs. NCI-supported research programs. Many NCI-funded researchers working at the National Institutes of Health campus, as well as across the United States and world, are seeking ways to address prostate cancer more effectively. Some of this research is basic, exploring questions as diverse as the biological underpinnings of cancer and the social factors that affect cancer risk. And some is more clinical, seeking to translate basic information into improving patient outcomes. The programs listed below are a small sampling of NCI's research efforts in prostate cancer. The Cancer Biomarkers Research Group promotes research on cancer biomarkers and manages the Early Detection Research Network, EDRN. EDRN is a network of NCI-funded institutions that are collaborating to discover and validate early detection biomarkers. Within the Center for Cancer Research, the Prostate Cancer Multidisciplinary Clinic, PCMC, provides comprehensive consultations on diagnosis and treatment options to people with newly diagnosed prostate cancer. The prostate specialized programs of research excellence, prostate spores, are designed to quickly move basic scientific findings into clinical settings. The prostate spores support the development of new therapies and technologies and studies to better understand how to prevent, monitor, and treat prostate cancer. The NCI Cancer Intervention and Surveillance Modeling Network, CISNET, focuses on using modeling to improve our understanding of which men are most likely to benefit from PSA-based screening. CISNET also studies treatment strategies for prostate cancer and approaches for reducing prostate cancer disparities. The NCI Genitourinary Malignancies Center of Excellence, GUMCOE, brings together scientists studying genitourinary cancers, GU, from across NCI's Center for Cancer Research and the Division of Cancer Epidemiology and Genetics, as well as investigators who study GU malignancies in other institutes of NIH. The goal is to provide a centralized resource and infrastructure to accelerate the discovery, development, and delivery of interventions for the prevention, diagnosis, and treatment of these cancers. The research on prostate cancer in men with African ancestry, RESPOND, study is the largest ever coordinated research effort to study biological and non-biological factors associated with aggressive prostate cancer in African American men. The study, launched by NCI and the National Institute on Minority Health and Health Disparities in partnership with the Prostate Cancer Foundation, is looking at the environmental and genetic factors related to the aggressiveness of prostate cancer in African American men to better understand why they disproportionately experience aggressive disease. Is a genomic test better at finding aggressive prostate cancer? Subscribe. October 13, 2022, by Nadia Jaber. Human prostate cells grown in a lab. The Decipher test looks at the activity of 22 genes in prostate cancer cells. Credit, National Institutes of Health. If you were recently diagnosed with prostate cancer, there are a few different ways to gauge how aggressive the cancer is, in other words, to see if your cancer is likely to spread beyond the prostate. In a new study, a genomic test appeared to be better at finding aggressive prostate cancer than conventional tests. The genomic test, called Decipher, looks at the activity of 22 genes and has been shown to predict the risk that a prostate tumor will spread, metastasize. Conventional tests, on the other hand, look at clinical markers like Gleason score and PSA level. For some men in the study, the Decipher test showed that their cancer was high risk even though conventional tests pegged it as lower risk. This discrepancy appeared to happen more frequently for African American men than other men, the study found. Results of the study, partially funded by NCI, were published September 2 in JNCI, Journal of the National Cancer Institute. It's important to know how aggressive a patient's cancer is so that their treatment can be tailored, explained the study's lead scientist, Kos Jumoa, MD, PhD, chair of the Department of Radiation Oncology at the Moffitt Cancer Center and Research Institute. That typically means more treatment for high-risk tumors and less treatment or no active treatment for lower-risk tumors, he said. What this study points us to is, beyond just the clinical markers that we've been using, we now have to start thinking about genomics too, said Fatima Karzai, MD, of NCI's Center for Cancer Research, who was not involved in the study. I would tell patients that if they're newly diagnosed with prostate cancer, and they want to have a really in-depth conversation about how to get treated, they should ask their doctor if the Decipher test should be at least a part of their evaluation, Dr. Karzai added. The Decipher test has been in use for many years and is covered by Medicare, Dr. Karzai noted. But professional medical groups haven't widely recommended the use of Decipher or other genomic tests by people with newly diagnosed, localized prostate cancer. Adding genomic information. For many years, doctors have used clinical markers to estimate the risk that a prostate tumor will spread to other parts of the body. But as time went on, we realized that we were missing certain more aggressive tumors. And that was happening more frequently in men of African origin, Dr. Yamoa said. So, we started to consider whether our clinical classifications may be suboptimal. They are good, but not as good as they could be, he explained. He and his team wondered whether adding a layer of genomic information could reveal aggressive features of prostate tumors that the clinical methods were missing. To test this idea in a prospective study, the researchers first enrolled a group of men who self-identified as African American. They then enrolled a group of men who self-identified as non-African American and who had matching clinical markers such as age, PSA level, Gleason score, and the treatment they received. It's pretty significant that they were able to find so many African American men to go on the trial. Usually, if you look at other studies, the rate of enrollment is very low for African Americans, Dr. Karzai noted. Hidden high-risk cancer. All 226 participants had prostate cancer that had not spread beyond the prostate, localized cancer. The researchers compared the results of the Decipher test with those of the clinical methods. Because the men all had very similar clinical markers, the researchers expected to see similar Decipher results, Dr. Yamoa said. Instead, they found a discrepancy. Some men had cancer that was classified as lower risk by clinical methods but as high risk by the Decipher test. According to one clinical method, 11 African American men and 7 non-African American men had low-risk cancer. Yet the Decipher test found that 18% of those African American men were at high genomic risk of their cancer spreading within 5 years. Clinical methods found 37 African American and 37 non-African American men with favorable intermediate risk cancer, a term that describes cancers somewhere between low risk and intermediate risk. But the Decipher test found that 38% of those African American men and 19% of the non-African American men had high genomic risk cancer. Imaging technique accurately detects prostate cancer spread. PSMA PET-CT finds metastases better than standard imaging approach. Overall, African American men were more than twice as likely as non-African American men to have cancer that was recategorized as high risk based on the Decipher test, the researchers found. I think this study gives us a platform to move the Decipher test into even bigger trials, Dr. Karzai said. And in future studies, she said, it will be important to find out if prostate tumors at high genomic risk based on the Decipher test do in fact spread faster or grow back faster after treatment. The next phase of the ongoing study will address that, Dr. Yamoa explained. Every year, participants with high genomic risk cancer will get an imaging test, called a PSMA PET scan, to check if their tumors have spread beyond the prostate. That, he said, will also help answer questions like, what do we do with these so-called aggressive tumors when we catch them early? How can we actually do something about it? Considering the environment, African American men are more likely to develop prostate cancer, to have it at an earlier age, and to die from the disease, but it's not clear why. It's possible that conventional methods for assessing prostate cancer aggressiveness are missing more aggressive tumors in African American men, Dr. Karzai said, leading to worse outcomes. Why African American men seem to have more aggressive tumors is another question, Dr. Yamoa said, but it's likely related to environmental, social, and economic factors that can change tumor biology and genomics. For example, there are data suggesting that diet, metabolism, stress, all these other things impact disease, he continued. It's possible that more African American men are exposed to conditions, such as high levels of air pollution or limited access to healthy foods, and other social determinants of health that lead to biological changes encouraging the development and growth of aggressive prostate cancer, Dr. Yamoa explained. Ultimately, Dr. Karzai said, one of the things we all need to do better is try to get people of all different backgrounds into clinical trials. That way, researchers can make sure they are developing tools and treatments that work for everyone, she said. Surveillance more than doubled between 2014 and 2021, the time period covered by the study. The finding is encouraging and shows that the use of active surveillance is headed in the right direction, said the study's lead investigator, Matt Cooperberg, MD, of the University of California, San Francisco, UCSF, who reported the findings on May 15 at the American Urological Association's, AUA, 2022 annual meeting. But they are still not where they need to be. Of particular concern, Dr. Cooperberg noted, is the finding that in some urology practices only a small percentage of patients with low-risk prostate cancer are on active surveillance. There were urologists in some practices who did not have a single patient with low-risk disease on active surveillance. Those findings fly in the face of recommendations from leading medical groups that say active surveillance is the preferred approach for men diagnosed with low-risk prostate cancer. Those doctors are doing their patients a disservice, said Howard Parnes, MD, chief of the Prostate and Urologic Cancer Research Group in NCI's Division of Cancer Prevention, who was not involved in the study. If a patient meets the criteria for low-risk disease, active surveillance needs to be a central part of the conversation. Reconsidering immediate treatment. Most prostate cancers diagnosed with PSA-based screening, which became widespread in the United States starting in the early 1990s, are low risk. Generally speaking, that means they are small, confined to the prostate, and not considered to be aggressive according to a common grading system known as the Gleason score. Nevertheless, throughout the 1990s and well into the 2010s, many men diagnosed with low-risk prostate cancer had immediate treatment with surgery or radiation. What is low-risk prostate cancer? According to the most recent guidelines from the AUA and National Comprehensive Cancer Network, NCCN, low-risk prostate cancers are those that meet these criteria. PSA level of less than 10. Gleason grade group 1, Gleason score 3+3. Clinical stage, T1 T2A. Learn more about PSA testing, Gleason grade groups, and clinical staging. NCCN also has a very low-risk category, for which active surveillance is also recommended. But even in the early days of widespread PSA screening, questions were raised about whether these screen-detected cancers were actually dangerous. Studies followed that echoed those concerns, concluding that many of these cancers would likely never grow to the point where they would even cause symptoms, let alone become life-threatening. Another alternative to immediate treatment is watchful waiting, simply waiting for symptoms before pursuing any further testing or treatment. But because prostate cancer can be deadly once it spreads beyond the prostate, use of watchful waiting in men with low-risk prostate cancer has been limited. Protocols for active surveillance were first proposed in the mid-1990s and have since been studied and implemented in various forms. It's only fairly recently that leading medical organizations felt the data on the safety of active surveillance were strong enough to formally recommend it as the preferred approach for men with low-risk disease. How is active surveillance done? Although the protocol can vary, recommendations for active surveillance generally call for routine PSA tests and prostate biopsies to check for any indication that the cancer might be growing. For example, patients at Montefiore Health System in New York City get a PSA test every 3-6 months, at least initially, and an MRI-guided biopsy a year after diagnosis, said Kara Watts, MD, a urologist at the hospital who specializes in treating prostate cancer but was not involved in the study. After the initial PSA tests and biopsy, how often they are performed depends largely on the patient's particular situation, Dr. Watts explained. We have a flexible protocol, particularly for people at both ends of the age spectrum, she continued. For a man in his 70s and a life expectancy of 5-10 years, based on other health conditions and other factors, she said, additional PSA tests or biopsies may only be conducted every few years or only if he has symptoms. An otherwise healthy man in his 50s, on the other hand, will usually continue to have PSA tests and MRI-guided biopsies on a schedule similar to the initial protocol. At the NIH Clinical Center, where Dr. Parnes sees patients, in addition to routine PSA testing, MRI-guided biopsies are used to help inform decisions around whether to pursue active surveillance and as part of the surveillance protocol. MRI-guided biopsies have been shown to improve the detection of intermediate and high-grade prostate cancer, but they aren't required for active surveillance for low-risk prostate cancer, Dr. Parnes explained. Many studies using standard ultrasound-guided biopsies have demonstrated the long-term safety of active surveillance in men with low-risk prostate cancer, he said. Genetic and molecular testing are also making their way into doctors' decisions to recommend active surveillance and as part of the surveillance protocol exit disclaimer. At NCI, for example, men with a family history of cancer or who are diagnosed with intermediate-risk prostate cancer are recommended to undergo testing for mutations in the BRCA2 gene or other genes involved repairing damaged DNA, Dr. Parnes said. Finally, regardless of the doctor or hospital where a patient is being treated, if biopsy results suggest that the cancer grade is progressing, men will generally be advised to receive immediate treatment. The number of men on active surveillance who eventually get treated with surgery or radiation varies. In a recent, large observational study involving over 8,000 men, just under half of those on active surveillance received definitive treatment within 5 years. More active surveillance, but not enough. To conduct their study, Dr. Cooperberg and his colleagues looked at data from all men newly diagnosed with prostate cancer in the AUA Quality Registry. This registry collects real-time data from more than 240 participating U.S. urology practices and more than 2,100 urologists. Overall, of the more than 84,000 patients covered by the study, 20.3% were diagnosed with low-risk disease. The number of men diagnosed with low-risk disease actually fell during the study period, from about 24.6% in 2014 to 14% in 2019. That finding is consistent with other recent studies showing a decline in low-risk diagnoses, which researchers have attributed to fewer men being screened via PSA testing. But even as diagnoses of low-risk disease have dropped, more men with low-risk disease are opting for active surveillance, Dr. Cooperberg reported. In 2014, 26.5% of men with low-risk prostate cancer chose active surveillance. By the end of 2021, 59.6% did. Rates of active surveillance also increased among men diagnosed with intermediate-risk prostate cancer, which is considered to have a modestly greater likelihood than low-risk prostate cancer of progressing to the point where it could be fatal. The steady uptick is welcome news, Dr. Cooperberg said. But he also highlighted the relatively extreme variation in the use of active surveillance across the country. The researchers found that rates of active surveillance for men with low-risk prostate cancer can range from 7% to nearly 80% by urology practice, he said. And, depending on which individual doctor's door you knock on, even within a given practice, rates range from 0% to 100%. The variability in the use of active surveillance is alarming, Dr. Parnes said. It likely reflects, at least to some degree, entrenched patterns of care among some urologists. For some, I suspect their feeling is, I treat cancer, and this is cancer. I'm not having this conversation about active surveillance, he said. Dr. Watts agreed. It's likely that some doctors just aren't discussing active surveillance, or they're portraying it in a way that biases patients toward definitive treatment, she said. Exceptions and barriers to active surveillance. In his UCSF program, Dr. Cooperberg said, about 95% of men diagnosed with low-risk prostate cancer are put on active surveillance. As an academic center that began implementing and studying active surveillance in the mid-1990s, that's likely higher than what is typically seen in the United States, he acknowledged. But a reasonable target for the time being is around 80%, he said. That's consistent with where rates top out in countries like Sweden and in other large, integrated healthcare systems in Europe where active surveillance has long been standard practice. The bottom line, Dr. Cooperberg said, is that even though the vast majority of men with low-risk prostate cancer should be put on active surveillance, there will always be exceptions. Those exceptions, for example, can include men with a strong family history of prostate cancer or who have urological symptoms related to the disease that immediate treatment can help to alleviate. There can also be considerations that go beyond clinical or biological factors. For patients in rural areas or those who lack reliable transportation, anything that requires regular visits to the hospital or doctor's office over a long period could push some men toward choosing immediate treatment, Dr. Watts said. In addition, she noted, it can be challenging to explain the medical basis for active surveillance. In some patients' minds, opting for active surveillance means missing a window of opportunity for cure, she said. The C word is scary for a lot of people, Dr. Watts continued. And in this case, a lot of the art of medicine is being able to explain Why active surveillance is appropriate.